Good evening and welcome to our Volison live TV event. Thank you very much for joining us this evening. This session will be an opportunity to exchange best practice between our Volison Club members and key opinion leaders in different clinical applications on various case reports. Our guests tonight are already on their place and on writing your questions. In order to raise your questions, please send an SMS using enclosed phone numbers. These questions will arrive here in our studio, and our expert will try to answer them. I'm here with our three guests tonight, with Daniela Fischerova from Charles University Hospital in Prague, Professor Yves Ville from Necker Hospital in Paris, and Bernard Benoit from Princess Grace Hospital in Monaco. Welcome to our first session, Volison Live TV, and thank you very much for joining us tonight. Our first talk this evening will be conducted by Daniela Fischerova. She will speak about ovarian masses, rules and measurement using Volison signatures and expert series. You can send your questions during the talk by SMS. At the end of the session, Daniela will have a few minutes for answering those.
I would like to speak about diagnosis of ovarian masses based on data retrieved from the largest ultrasound study called IOTA study. This study was aimed to develop and to test different prediction models and rules to help less experienced examiner to differentiate benign and malignant masses. However, the first step was to use the standardized terms, definitions and measurements, which is being published in 2000 by IOTA Group. And I would like to walk you through IOTA terms as being presented on this poster distributed by GE. First, how to differentiate tumors and cysts. The unilocular cysts are cysts without any solid component, without the presence of septa, and without the presence of a solid component. For instance, the presence of incomplete septa is not regarded as a solid papillary structure. And also the presence of the excrescences associated with the chronic salpingitis, like the cogwheel signs, are not regarded as a solid papillary projections unless their height is more than 3 or equal to 3 millimeters. Then it is solid papillary projection. So we have the IOTA terms, and using the IOTA terms we can describe the ovarian masses. The main IOTA derived prediction models are logistic regression models LR1 and LR2, which on temporal and external validation have both shown an excellent diagnostic performance. But the LR2 requires, for the assessment of the risk of malignancy, only 6 variables. Therefore, is more useful for us in clinical practice. The first is a demographic variable age, and then the presence or absence of ascites, the presence of a blood flow within a solid papillary projection, and the maximal diameter for the solid component, the presence of the internal irregular wall, and the presence or absence of the acoustic shadows. And I would like to show you how to use these logistic regression models. This is a patient, 35 years old, and she was referred for adnexal tumor. We can see that the tumor mass is inside the ovary. It is unilocular solid tumor with a solid papillary projection. A blood flow is within the papillary projection, and the mass regarded, if we use the LR model and we put the variables, we can see that the age is 35 years, the ascites, because the video is not running, the ascites was not present, the blood flow was present within the papillary projection, the maximal diameter was 37 millimeter of the solid component, the cyst wall was irregular by definition because of a solid papillary projection, and the acoustic shadows was not present. So if we put these variables in the model, which can be uploaded from the websites of GE or IOTA websites, we reach the estimated risk of malignancy more than 60%. The second approach, how to describe the adnexal masses, are simple ultrasound rules, which are based on ultrasound features which are highly pathognomic for the presence of malignant mass and for the presence of benign mass. These rules are so simple that can be used by an examiner with less experience, without need of computer, without need of the CA125. And the mass is evaluated as a malignant if only malignant feature or features are present in the absence of benign feature. The mass is regarded as a benign if only benign features are absent, one or more, in the absence of malignant features. However, if both benign or malignant features are present, or if non-features are found, the mass is regarded as inconclusive. And this is a case of another patient where on diagram is visible that the mass is poorly unilocular, that there is an acoustic shadow and no blood flow. It should be now presented on video, however the video probably doesn't run again. And this mass is, according to simple ultrasound rules, regarded as a benign mass. So if you would like to be more informed about the diagnosis of ovarian tumors, please attend this IOTA Congress, which will be held in 2 weeks in Leuven. And the IOTA rules, terms and prediction models will be introduced there as well. Thank you for your attention.
You can find this measurement already on our LR2 measurement on our system, on the S and E series, and you can download the posters mentioned by Daniela. I have a question, Daniela, for that. In terms of malignancies, ovarian, it's a huge pathology in Europe, and in terms of mortality, do you have any idea about the growth of this pathology in Europe or in the different, and where we have the most important case in Europe today?
I think that the incidence of malignant masses of the ovary is probably not really growing, but also the mortality is not significantly changed during the last years, although we have maybe better chemotherapy, better surgery, but still these tumors, I mean the ovarian cancer, is recognized in very advanced stage, and the mortality is still high. Therefore, there were a lot of studies focusing on screening program, but recently I think there is not any reliable or not any screening program effective to reduce the incidence of the malignant tumor. So the incidence is still the same, and screening program which would be effective doesn't exist.
We have received a question from our members. Do you need to have a computer or smartphone to access a mass or as benign or malignant?
Thank you. If we use the simple ultrasound rules, IOTA simple ultrasound rules, we just need, for instance, the poster distributed by GE to have this poster in close to the monitor of ultrasound machine, and we can easily, during the ultrasound examination, evaluate the patient, whether there are the malignant features present within the mass or benign features, and we can calculate only in our mind whether the mass is benign benign, malignant, or inconclusive. In cases that the mass is regarded as inconclusive, we cannot make the diagnosis, and we will send the patient for subjective assessment by an experienced examiner. So we don't need any computer in case we use simple ultrasound tools.
Okay, thank you. We have another question. Why do we need to differentiate benign and malignant tumor, and what is the impact?
Thank you. It's, again, very important question. If we identify the benign mass with really high accuracy, we can avoid unnecessary surgery and reduce morbidity and reduce costs. On the other hand, if we correctly classify the mass as a malignant, we send the patient directly to the gynae-oncological unit, and the prognosis of patient is significantly improved if it's treated directly in the center with the appropriate surgery and appropriate further management. So it's for extreme interest to recognize whether the mass is benign or malignant.
Thank you. Our second talk this evening will be done by Bernard Benoit from Princesse Grace Hospital in Monaco. He will speak about the 3D and 4D tools we have on our different products in his daily practice. Please send us your questions during the presentation. Bernard?
Thank you, Arnaud, and good evening. So I will talk about all the tools I am using on my daily practice with E10. So we will start first with gynae. This is Uterus, and what I am using on my everyday practice in gynae, this is OmniView. With the OmniView, you can choose to draw a line on the endometrium, and you have a nice view of the uterine cavity. But if you want to have the real uterine cavity from the fundus to the cervix, you have to use a polyline. With a polyline, you just have to draw the line exactly on the endometrium. And also you can increase the contrast by using the volume contrast imaging. And in this case, I use the X-ray mode and always with a thickness between 5 to 10 millimeters. And now we'll move to first trimester scan, early stage at 8 weeks of pregnancy. This was with a HD Life. And you can see here I am turning a knob, and this is a silhouette. With a silhouette, you can see with transparency, you can see the outline of all the interface. So here, it's easy to see exactly the size of the two gestational sacs. It was a dichorionic twins with one small gestational sac. You can see the two embryos, the two yolk sac, and the embryo with the same size. And you can change the position of the lightning. And now we will move to the 12 weeks, 13 weeks of pregnancy. And I am always using the magic cut, because with the magic cut you can clear, you can remove some part in front of the fetus. So this is the only way if you want to obtain a nice complete view of this fetus. Rotate, and now I will remove the yolk sac. You can see the yolk sac here close to the bottom. And this is a view of this fetus. And this is a display with a random mode, the surface random mode, the classic one. But now we can use the new HD Life. This is a HD Life. And the main advantage of the HD Life is that you can move the position of the lightning, and you have a kind of fetoscopic view. And in this case, I will apply the silhouette. That means this new transparency mode. And this is with the silhouette. And if you push the knob to the maximum, you will see in the frontal part of the head the two lateral ventricules. Now we move, and you can see the two anterior part of the lateral ventricle with this transparency mode. This was an acquisition made with a stick, with a power Doppler, display with a TUE, and now with multiplanar view. And this is a 3D rendering with a new HD Life color. It's glossy, but you have more impressive picture. So now this is the main advantage of the electronic probe. It's a B-plane. With a B-plane you can work on one plane on the left, and you just have to move the line. And when you move the line on the right window, you can see the orthogonal plane. The heart, it's quite difficult sometimes to show on the same plane the great arteries. You have to move the probe to show here the pulmonary artery and the aorta. But it's really difficult on a plane to show the two vessels together. So what I really like to use is VCI A-plane combined with inversion mode, and I choose a thickness around 10 millimeter. And this is the result. It's done in a real time with 25 frames per second, and you can show the crossing of the great arteries. You can do it in real time. If you rotate the probe, you can follow the aortic arch and the aorta. And this was an embryo around 9 weeks of pregnancy with glass bodies. That means it's a gray, and also the color Doppler. This is a standard glass body, but now we can also apply the new color Doppler with HD Life. And I will do the same. Now you can see the vascularization, and if I move, I increase the transparency, the silhouette. You can see the different part of this embryo, and here the brain cavity, especially the lateral ventricule at this stage of pregnancy. Now, again, the use of the VCI A-plane, but I will use it now with a maximum mode, and I choose a thickness between 10 to 15 millimeter. And this is really helpful for the examination of the skeleton. You can see on the left the standard 2D picture, and this with on the right with the VCI A-plane with a maximum mode. Now this is an acquisition of the umbilical cord, and the 3D rendering of this umbilical cord with one vein. The vein here is in red, and the two arteries. Now again the B-plane, this is a brain, axial section of the brain, and if you put the line here, you have simultaneously the coronal plane on the second one. And don't forget that with the main advantage of this electronic probe is 3D and 4D, and especially with a high frame rate, because now it's possible in 4D to move to 5 to 10 frames per second, and with the old probe it was only possible to have 3 to 5 frames per second.
Okay, thank you very much. We have a few questions from our members. The first one is how are you using the silhouette mode in your daily practice, in your daily routine? The second one is we will combine the different questions at the same time. What is the best gestational age to use it? And the last one, are you using the electronic matrix 4D probes for the routine scanning?
Okay, first about the silhouette, I use it mainly in the early stage of pregnancy, and this is a really good tool. For me, it's improved when I am using the magic cut, because with this transparency you know exactly where you can cut. So I use it on my everyday practice when I use a magic cut, especially in the first trimester of the pregnancy, and also sometime in case of malformation in second trimester of pregnancy. If inside the malformation we have a cystic part, I will use it. And about the new probe, the electronic probe, when I have to do my scan from the abdominal way.
Yeah.
I always use this probe in 99% of the case because I don't want to change. And the VCI A plane, I can
So
use
routine
it
scan.
only with this probe, and especially with the inversion mode for the heart, because I always show a picture of the heart with the crossing of the great arteries with inversion mode.
So now you can say the VCI and the inversion mode, it's in the daily routine for all patients?
Yes, it's for me, it's in my daily routine. And also the improvement of frame rate for 4D.
Thank you very much, Bernard. Very impressive pictures and very informative. If you are interested to learn tips and tricks from Bernard Benoit, especially on how to optimize your system and its settings, you can find him 4 times a year as a lecturer and trainer on our Visius course in Vienna and in Berlin. Please find the details on our different event and venue of this course in our Volison Club homepage. The last talk this evening will be done by Professor Yves Ville from Paris. He will speak about interventional procedure with the new electronic 4D technology using on the Volison E10 system. Thank you very much, Yves, for joining us this evening.
Thank you, Arnaud. Usually when we move to a talk with invasive procedures, we see the Prurus, the Crapius machine, and the Prurus images. Although this is kind of a difficult paradox to sustain with the urge to safety, and we are performing here the most dangerous procedures for our patients. There are basic principles that should be followed. They've been known for a long time, known as the King's methods, as it was taught by Kypros Nicolaides to his numerous fellows over the years. You should hold your transducer perpendicular to the table, not towards the round abdomen. The needle, not using any magnification, the needle should be entered at 45 degrees either to the table or to the cable of the probe, which is exactly the same if the probe is actually held 90 degrees to the table. And then the tip of the needle should be followed from its entry into the skin right to the middle of the target, which will also be the middle of the screen. So theoretically, you could do that completely blind, closing your eyes, but obviously it's also recommended not to close your eyes. We've been working on this for over a decade, trying to make up for the difficulty to keep online and to track not only the tip of the needle by the whole length of the shaft. And all the process we've been using have been quite cumbersome and never really ended into a single machine. The idea is pretty simple in the concept and sometimes difficult technically. The needle should be seen from its entry in the skin down to the very target of the tip of the needle, seeing all the shaft and every structure it's gone through. Now, when we received the E10, we decided recently to have a look at what help it could be of into proceeding with those difficult sometimes procedures and definitely always dangerous. Even for as a simple dummy procedures, an amniocentesis or an amniodrainage, it is quite useful to see where the needle is in comparison to the structure aside. So on the left screen, you see the needle arriving at 95 degrees, at 45 degrees as mentioned, right in the middle of the screen. And then the tracker, the line, shows you in the biplane, the orthogonal plane, where you see exactly how far you are with the tip of your needle in a cross-section, how far you are from the left eye of this fetus. So this is quite in principle and a simple procedure, a good principle to follow. Fetal blood sampling, chordosynthesis, is definitely probably the most adventurous and dangerous diagnostic test in prenatal diagnosis. That would allow you, this technique you've just seen, and we're going to see again, to adjust the positioning of the tip of the needle in the umbilical vein. Indeed, when you will have define the right plane, and you're ready to enter the plane and the target with 45 degrees to the table, etc., etc. When you will reach the actual cord, you will have some hesitation to push the needle right in the vein and not in the Wharton jelly or in the artery. On the left, you got your 45 degrees, and the needle is holding upon the cord. On the right-hand side of the image, the perpendicular plane shows you that in this particular case, the needle went aside in the Wharton jelly, and it only requires minimal adjustment following now on the right screen and forgetting about the the left one, in order to adjust and put the tip of your needle back into right the middle of the umbilical vein. So this is, again, a safety issue, and the right positioning does not always appear on one plane. At a very early stage, meaning late first trimester, it might be also a prospect for gene therapy or stem cells to actually get to the very early fetal blood circulation and the very early cord. So this is a 12-week fetus, and you see again on the left the needle in the appropriate perpendicular planes to the table, touching on the cord, and only on the right-hand side you see the tip of the needle for the adjustment before getting right and sharp into the umbilical vein. More complex and therapeutic procedures, tapping a pleural effusion, should see where the tip of the needle is in relation to the content of the thorax, because there is no way to damage the heart or even the lung. So this is a very hydropic fetus with polyhydramnios, and therefore the image is quite fuzzy, and you don't always manage to keep perpendicular to your target, and also the rib cage is an obstacle. So you can see the needle coming on the right-hand side with some bubbling initially, and then the tip of the needle tells you you are in the pleural cavity, you're not touching the ribs anymore, and you're in the right place to push, to either aspirate or push your drainage tube if needs to be. So that's the next step, is to put a shunt, and the drainage tube needs to be, you need to be absolutely certain or where you're going to release the first loop, and then when you remove your drainage trocar, where you're going to leave the second loop. There would be a complete failure to either leave one or the other outside the precise target, and the risk of misplacement is a common pitfall of this procedure. So now the trocar is has entered right in the pleural cavity. On the right-hand side, you see you are at the right distance. You see the first loop coming out of the trocar and being released exactly in the pleural cavity and not in the thickened by the edema, the thickened wall of the thorax. Then the shunt is the trocar is going to be slowly removed. Once you arrived outside, again, you can make sure your second loop is released at the right place for its entire length. Another and even more difficult procedure, because it's a matter of life and death for the second twin, is the grasping and proper coagulation of the cord of one monochorionic twin when it endangers the whole pregnancy and the life of the co-twin. So grasping the cord with a forceps under ultrasound in only one plane has been difficult for everyone who's tried it. So it allows you, on the left-hand side, always use your tracker at the very tip of any instrument you're using, so that the perpendicular plane will show you where your instrument is towards the target. And when you are hesitating, trying to grasp the cord, you will actually see that the two blades are properly circling the cord, and that the whole cord is captured within the blades. And it is, again, a matter of a very, very important matter of safety in those difficult procedures. and you will be able to see the grasping of the whole loop with the forceps and the proper coagulation. You know that nothing is actually leaking out of the procedure. So this was quite a quick tour with a very new machine we've had for some time. I will welcome your input as you will discover yourself what you can do with it. And thank you for allowing me to presenting this preliminary data.
Thank you very much, Yves. We have a few questions from our members. Is it too difficult to concentrate on two planes at the same time? And do you have any difficulties in terms of frame rate on this both plane? And do you have the same quality also in terms of image?
Yes, absolutely. I mean, you've got two hands and one cerebellum, and the three things should work together. So you can't add a discrepancy between what your both eyes are looking at. So it would be extremely dangerous to look like Marty Feldman in one of the Mel Brooks movie, and one eye on the left and the other eye on the right. So you should concentrate on either side of your screen. The initial approach is always on the left side with the sagittal view. And once you are reaching to your target, you forget about this one, and you switch completely with your both eyes and your single cerebellum to the right side, and that's where you adjust the needle, basically, or whatever other instrument, for the fine tapping or approach.
Thank you very much, Yves, for this nice talk, and I think it clearly shows what is impressive and new opportunities this technology is offering us. At the end of this year, we will organize a dedicated course for electronic 4D users in order to train them and also to share experiences and best practice almost each other. Please contact your local GE representative for more details and for registrations. Now we have to reach the end of today's session, and thank you, Daniela, thank you, Bernard, thank you, Yves, for your participation, for these excellent presentations. And now I will hand over to Gerald Safriksberger, who will conclude the session, and thank you and goodbye for your participation. Thank you. Gerald.
So, thank you very much. Thank you, Arnaud. Thank you to the speakers. And also, thank you to all of you who have joined us this evening for our first Volus on Live TV event from Paris in France. As you have seen, Volus on Live TV is a new format for us that we want to broadcast to you a few times a year, starting now. We want to use this platform to invite well-known speakers, experts from various clinical applications to introduce interesting cases or technologies to you. As well as we want to give you a tool to ask questions online and share your experiences. I'm happy and proud to tell you that today we had close to around 1,000 visitors from all over Europe to our first Volus on Live TV show. Together with our Volus on Club and our International Academy of Medical Ultrasound, we are trying to provide you support and education in various formats that should be available to you 24 hours a day. Finally, again, a big thank you to our speakers today, and I wish you all a good evening from Paris.
Thank you.
Thank you.